So we very much appreciate Dr. Fatimah Aldurayhim is presenting the webinar this evening. She holds a bachelor's degree from Maastricht University in the Netherlands and completed her paediatric neurology training at King Fahd Specialist Hospital in Saudi Arabia. She is a board-certified paediatric neurologist and is currently completing a fellowship in paediatric movement disorders at the University of Calgary. I hand it to you, Dr. Aldurayhim.
Thank you for the nice introduction. The topic of today is about comprehensive behavioral intervention for tics, or CBIT, an evidence-based therapy designed to help people manage their tics and improve quality of life. Here is what I will cover today. I will start with a quick overview of tic disorder to set the stage. Then we will discuss the biobehavioral model of tics to understand why tics happen. After that, we will discuss behavioral treatment focusing on HRT and CBIT. We'll then discuss how these treatments work and review the evidence supporting their effectiveness. Finally, I will finish with some key points. Now, let's start with a brief overview of tic disorders. Tic involve quick, repeated, non-rhythmic movements or sounds. They are grouped into motor tics and vocal tics. Motor tics can be simple, like eye blinking or nose twitching, or more complex, such as touching objects in a particular pattern or making coordinated movements. Vocal tics can be simple, like throat clearing or sniffing, or more complex, such as repeating words or phrases or using inappropriate language. Tics are often preceded by an unpleasant sensation called premonitory urges. These can feel like tension, pressure, an itch, or a sense that something just isn't right. These urges usually build up when tics are suppressed and relieved after the tic happens. Understanding these sensations is important as they play a key role in how we explain and treat tics using behavioral approaches. Tic disorders are classified based on how long they last and how complex they are. Provisional tic disorders refer to tics that last less than a year. Persistent or chronic motor or vocal tic disorders involve either motor or vocal tics, but not both, that persist for more than a year. Tourette syndrome is diagnosed when both motor and vocal tics are present for at least 1 year. In all three conditions, onset must begin before the age of 18. Now, in terms of epidemiology, provisional tics occur in about 3% of population, while chronic tics affect around 1%. Studies have found that males are nearly 4 times more likely than females to develop a tic disorder. Tics typically start between the age of 6 and 9, often starting as simple motor or vocal tics that gradually become more complex. Their intensity tends to wax and wane over time. Severity usually peaks between the age 8 and 12, and many individuals experience significant improvement or even remission by adulthood. This pie chart shows the prognosis of tic disorders. About 1/3 of individuals experience complete remission. Another 1/3 show no significant change, and the remaining 1/3 have a reduction in tic severity over time. Tics can lead to reduced quality of life and psychosocial challenges. Comorbid conditions are very common. Nearly 90% of individuals have at least one comorbid condition in their lifetime. The most frequent are ADHD, OCD, anxiety, and depression. In some cases, these comorbidities contribute more to functional impairment than the tics themselves. There are two main treatment approaches for tic disorders: medications and behavioral therapy. While medications are still used for severe cases, behavioral interventions are now the first-line treatment, as they target tics without the side effects of medications. Next, We will discuss the biobehavioral model, which explains how tics develop and persist. The biobehavioral model integrates the underlying biology of tics with the principles from behavior theory to explain the process that influence and maintain them. It's based on three main principles. Tics have a biological basis. Premonitory urge plays an important role in tic expression and suppression. Environmental and social factors can also influence tics. Studies have found that Tourette syndrome is highly heritable, with family studies showing an increased risk among first degree relatives. Twin studies have found that identical twins share tics about 50 to 90% of the time, compared with only 10 to 20% for non identical twins. Genetic studies suggest a polygenic pattern, meaning multiple genes contribute to risk, and there are even shared genetic links between Tourette syndrome and OCD. Studies have also shown that tics are linked to problems in specific brain circuits called corticostriatothalamic cortical circuits, CSTC, which help control movement. There is also abnormal dopamine activity, which affects how these circuits function and contribute to the development of tics. The second principle focuses on premonitory urges, which act like triggers for tics. Performing a tic relieves the unpleasant sensation, which reinforces the behavior. Studies showed that being aware of these urges is associated with better tic control. The third principle is that the frequency and expression of tics are influenced by both antecedents and consequences. Antecedents are factors that occur before a tic. These can be internal, such as stress, boredom, fatigue, or excitement, or external, like being in a specific environment, for example, watching TV, that can increase or decrease tics. Consequences are what happen after a tic, such as receiving attention, avoiding a task, or relief from unpleasant sensations. These consequences can actually increase tic severity and premonitory urges, reinforcing the tic over time. Now, let's move on to behavior treatment for tics. Unlike medications, behavioral approaches empower patients to gain voluntary control over their tics. These therapies have strong research support and are now recognized as first line treatment by the American Academy of Neurology. There are three main evidence based behavioral intervention for tics. The first is habit reversal training or HRT. The second is an expanded version of HRT called Comprehensive Behavioral Intervention for Tics or CBIT. The third is exposure and response prevention or ERP, which will not be covered here today. Let's start by looking at habit reversal training or HRT. Habit reversal training or HRT is the foundational behavioral therapy for tics. It was first developed by Azrin and Nunn in 1973. Habit reversal training has three key components. Awareness training, patients learn to identify their tics and the sensation that precedes them. Competing response training involves performing a movement that is incompatible with the tic to help suppress it. Social support, family or others provide encouragement and reinforcement to help practice these strategies outside of sessions. During the first interview session, the patient is asked to list all the tics and rank them from the most distressing to the least. In habit reversal training, each tic is addressed individually, starting with the most distressing and progressing to the least. Awareness training is the first step in habit reversal training, and it is important because tics are often semi voluntary and automatic. By improving awareness, patients can intervene before a tic happens. Awareness training involves the three parts: response description, response detection, and early warning training. This process helps patients consciously recognize the onset of a tic, allowing them to use a competing response in time. It begins with a response description, where the patient describes each tic in details, including the specific muscle group involved and the sensation they notice. Here you can see the patient demonstrating a tic that involves backward bending of the neck. Next is response detection, where the patients practice noticing their tics as they happen in real time. For example, the therapist might ask the patient to raise a finger each time they notice a tic during a conversation, as you can see here. Finally, early warning training helps the patient recognize the earliest premonitory urge or sensation before a tic happens. The patient is encouraged to notice this urge and raise a finger each time it happens during a conversation. Once the patient can accurately detect the targeted tic, they are taught to perform a competing response, a behavior that is physically incompatible with the tic. The competing response is voluntary, controlled, and subtle, so it can be done without others noticing. It's usually held for 1 to 3 minutes or until the premonitory urge subsides. For example, a backward neck bending tic can be countered by gently pressing the chin down and tensing the neck, as you can see here, while a throat clearing tic can be managed with slow diaphragmatic breathing. The patient is encouraged to use the competing response whenever the tic or premonitory urge occurs, and to maintain it for at least 1 minute or until the urge subsides, whichever is longer. This technique trains the patient to replace tic with more adaptive behaviors. Social support helps patients apply the skills they learned in therapy to everyday life, and is especially important for children and adolescents. Support person can prompt awareness and encourage use of competing responses, reinforce practice and successes, and helps track tic frequency and progress. Studies showed that HRT is most effective when family members actively participate and support the therapeutic goals. Therapists trains parents or caregivers to use praise and encouragement rather than punishment. They are also taught to reinforce the use of competing responses outside of therapy sessions. Now, let's move on to the expanded version of HRT, which is Comprehensive Behavioral Intervention for Tics, or CBIT for short. CBIT was developed by Tourette Syndrome Behavioral Therapy Institute and validated in large randomized controlled trials. CBIT focuses on teaching lifelong self-management skills, and it is a flexibly structured 8-session program delivered over 10 weeks. CBIT components include psychoeducation about tics, functional assessment and intervention to modify tic triggering contexts, relaxation training, motivational intervention to support adherence. Psychoeducation helps patients and families understand the neurological and behavioral basis of tics, that tics are involuntary and not the patient's fault, the role of a premonitory urge and reinforcement, and why behavioral treatment is effective. This understanding helps reduce guilt, stigma, and frustration, improving treatment engagement and motivation. Functional assessment identifies the antecedents and consequences that increase tic frequency. As previously mentioned, internal antecedents include stress, boredom, fatigue, or excitement. External antecedents like certain environment, for example, watching TV. Consequences like attention from others, escape from tasks, and relief from unpleasant sensation. These can, in fact, increase tic frequency. These factors are identified through interviews and self monitoring. When tic exacerbating factors are identified, individualized, function-based intervention strategies are implemented. This typically involves eliminating tic-exacerbating antecedents, such as reducing tic-related talk or avoiding activities that trigger tics. Teaching patients strategies to counteract internal tic-exacerbating factors like managing emotional responses. Removing tic contingent consequences by avoiding giving attention immediately after a tic, ensuring teachers do not excuse the child from a task when a tic happens, and not allowing the child to escape or delay activity because of tics. These interventions help reduce tic frequency and to promote adaptive coping strategies. Stress is one of the strongest situational triggers for tics. Techniques such as diaphragmatic breathing and progressive muscle relaxation are included in CBIT, as many individuals report that anxiety and muscle tension increase tics. Teaching children relaxation techniques helps them to manage stressful moments and support tics control. Motivational techniques such as reward programs are used in CBET to reinforce attendance, session participations, and homework completion. And convenience review are also done weekly. The therapist and patient review how inconvenienced the tics have been as a way to remind the patient about the importance of practicing the tic management strategies they have learned. Let's discuss other alternative treatment formats which aim to increase the availability and flexibility beyond the traditional in-person therapy. Given the limited availability of a trained CBIT providers, research has explored various delivery formats including telehealth delivery, intensive or abbreviated programs, self-help and online modules, and group-based therapy. Telehealth CBET has become widely implemented, especially since COVID-19 pandemic. Studies have shown that CBET delivered via telehealth result in tic reduction equivalent to in-person sessions. Internet-based CBET lead to significant improvement and high patient satisfaction. Telehealth offer flexible scheduling, home-based participation, and access for remote population. Minor challenges include occasional technology issues and reduced nonverbal feedback. Intensive CBET condenses the treatment into 4 to 5 consecutive days or 2-week programs, focusing on daily sessions. Studies showed that outcomes are comparable to standard CBET, with rapid improvement observed in 70 to 80 of the participants. This format is especially useful for families with limited availability or severe symptoms. However, long-term benefit requires ongoing self-practice and occasional follow-up sessions. Self-help CBET programs are delivered via DVD or online platforms. They are most effective for mild to moderate cases, providing easy access at minimal cost and leading to moderate improvement. Adherence is higher when supplemented with email or phone check-ins. However, these programs offer less individualized feedback. Group CBET is effective in reducing motor tics, however less effective for vocal tics. Group setting provide peer support and also normalize experience of living with tics. Now, let's discuss predictors of a treatment response, or the factors that can influence how well a patient benefit from behavioral intervention for tics. Studies have found that people already taking tic-reducing medication still show improvement with CBET, although their gains tend to be smaller compared with people who are not taking medication. Positive predictors associated with greater tic reduction include greater baseline tic severity, positive therapeutic expectation, greater homework adherence, especially in children, and more baseline obsessive compulsive symptoms. While negative predictors associated with less tic reduction include baseline anxiety and stronger premonitory urges. Patients with higher level of hypersensitivity or depression showed greater improvement with individual therapy. In contrast, those with higher premonitory urge scores show greater improvement with group therapy. Now, let's move on to mechanism of behavioral interventions. Identifying the mechanisms by which behavioral interventions reduce tics helps refine treatment strategies and improve their effectiveness. Key proposed mechanisms include habituation to premonitory urges, competing operant contingencies, associative learning process, cognitive and motivational changes, neurobiological modulation of corticostriatal circuits. According to the habituation model, behavioral therapy works because patients repeatedly experience premonitory urges without performing tics, leading to habituation and a decrease in urge intensity over time. As exposure continues, the nervous system adapts and the discomfort associated with the urge diminishes, reducing tic frequency over time. And according to the competing operant model, behavioral therapy creates new learning conditions that help individuals voluntarily suppress their tics. The key principles include positive reinforcement, like praise and achievement, enhances tic suppression behavior. Extension occurs when tics no longer reinforced by relief or social attention. Competing responses develop as incompatible behavior that override automatic tic execution. This model best explains how HRT and CBIT promote sustained tic reduction. Through awareness training and competing responses, patients form a new association. Premonitory urge now lead to engaging a controlled behavior instead of performing the tic. Tic triggering situation prompt relaxation or attention refocusing. With repeated practice, maladaptive association diminish and new adaptive patterns are reinforced. Behavioral treatment also target cognitive interpretation of urges and tics. Patients learn that premonitory urges are transient. Performing a tic is not necessary to relieve discomfort, and they can control their behavior despite internal sensation. This cognitive shift enhances self efficacy, motivation, and emotional regulation, contributing to sustained improvements. Interestingly, recent neuroimaging evidence suggests that behavioral therapy produces measurable changes in brain function. These changes correspond to improved voluntary tic suppression and reduced urge intensity. In summary, behavioral interventions for tics work through multiple complementary processes. Habituation leads to reduced discomfort from premonitory urges. Inhibitory learning enhances voluntary control. Associative learning leads to rewiring of stimulus response connections, while cognitive and motivational changes enhances tolerance and self-efficacy. Neurobiological changes improve brain connectivity and regulation. Together, these mechanisms explain both immediate symptoms reduction and long-term outcomes. Now, let's review the evidence supporting behavioral intervention for tics. Research has found that CBIT consistently reduces tic severity and tic-related impairment. It's effective for both children and adults. It provides long-term benefit lasting months to years. In a study by Piacentini and colleagues in 2010, 126 children were randomized to CBIT or supportive therapy. About 52% of CBIT participants were responders, compared with 18% of controls. You can see the responders highlighted in green. Importantly, tic reduction were maintained at 6 months follow-up. In another study by Wilhelm and colleagues in 2012, 122 adults were randomized to CBIT or supportive therapy. About 38% of CBIT participants were responders, compared with 7% of controls. The responders here again highlighted in green. 80% of responders maintained their gains at 6 months follow-up. Long-term follow-up by Espel and colleagues in 2022 showed that improvement from CBAT persisted for up to 11 years, that is over a decade of lasting benefit. Now, let's discuss the integration of behavioral therapy with pharmacotherapy. Stepped care model prioritizes behavioral treatment first, adding medication only when necessary. Behavioral therapy can complement medical treatment for severe or refractory cases. Using both approaches together often provide additive benefits, reducing tic severity and improving overall functioning. Medications such as guanfacine, clonidine, or Abilify may help decrease baseline tic activity, allowing patients to engage more effectively in therapy. Once behavioral control is established, medication can gradually taper under medical supervision. Let's finish up with some key points from today's session. Behavioral interventions are first-line treatment for tics. Empower patients to regulate symptoms voluntarily, effective as monotherapy or combined with medication when needed, offer sustainable improvement without reliance on medication, provide long-term skills for self-management and tic suppression, suitable for integration with family-based and educational interventions. I highly recommend this excellent paper by Dr. Douglas Wood, published in 2023, to provide a great overview of behavioral intervention for tics. This is the end of my presentation. Thank you all for your attendance and feel free to ask questions if you have any.
Okay, so just at this juncture here, I just want to give you a little bit of an overview of the CBIT resources we have on our website. Now, I spend at least one day a week at the Movement Disorders Clinic, and I speak with parents every time I'm there, quite a few of them. And one of their questions will be related to CBIT is where can they find a provider of CBIT? And one of my jobs is to try to find providers of CBIT, and as was said in the presentation, there is limited availability. But we have this directory of health professionals here, which I'm going to just show. And again, I don't know where you're from in Canada. I presume most of you are probably from Alberta, so we'll start with Alberta. So if we go to Alberta directory, you can see that there are not that many providers, but there are some, and certainly the main ones that we refer to in Calgary are the Family Psychology Place and Change Point Psychology. But it is ordered as per the major centres in Alberta, so at Edmonton, and I think we also have Red Deer at the bottom here. Okay, so if we go back to the top and we looked at Ontario, there's a good chance someone may be from there. Again, we have other providers, and you just need to just kind of look in there. For example, here, the Hotel Dieu Hospital, Expertise Tourette Syndrome, Comprehensive Behavioural Intervention for Tics. So that's just an overview of providers that are available across Canada. And should you, in your endeavours of trying to find a provider, find one that's not in our directory, please do let me know. Okay, so I'm just going to go back to the home page, go back to information about Tourette syndrome, and I'm just going to go down somewhat here. Now, this website here this portal, this site. It's called the Break Shop, and it's excellent. It is really about self-directed treatment, and it's the good thing about the Break Shop is it aims at youth, and the language that is used is certainly appropriate for youth. Again, it's something that the support of adults is required, but it does cover the main components of CBIT, and it has these sort of toolboxes. And if you just look around them, you get a real sense of how they support young people, and it can make them quite independent as well, because they have to go through the different toolboxes, but they will need adult support. And the great thing about this resource is that it's really kind of child friendly, but it's free. Okay, so I advise you to go to our website and look around there. We also have these sort of manuals here. There's this sort of parent workbook, and it's usually used to assist with homework that would be given by, as it says there, by the child's therapist during their therapy, but used widely and very effective. There's also TicHelper.com out of the United States, not dissimilar to the Break Shop. And it is a program of an 8-week intervention which does follow the components of CBIT. There is a cost to this, which is $150 US, which is a reasonable cost considering it is an 8-week program. Again, you could go to the website there, just have a look around. Very user-friendly, self-guided, but again, needed support of adults. And this is a book that we recommend to many of our patients, Nix Your Tics. Again, it's illustrated and it is aimed at children, and we do get a lot of parents telling us it's been very effective for them to be able to help their children manage their symptoms, but in a key that is relevant and reflects their age as well. So again, going down here, there are other books relating to Tourette syndrome, not directly to CBIT, but do look around this site here, and we're trying to, as we move along, as we do progress, we're trying to add to our resources. So just a little overview there of the resources that are available on our website.